Roll call, Shelley.
Yes, sir. Mike Dobbins.
Here.
Bill England.
Honey.
Dawson.
Here.
Harley Buzzard. Rex Jordan. Mary Baker Shaw.
Honey.
E.F. Smith.
Here.
Denise Taylor. Here. Victoria Vasquez.
Honey.
Brian Warner.
Honey.
And Kanan Duncan.
Honey. Honey.
Do you want to be a member?
Yeah.
I need to take a vote on that, though. I may not have known it, but we approved our minutes in the last health committee meeting, so we shall move on to reports. Lisa Pivek from our public health department, and Dr. Gann.
Make sure this is, can you hear me? I'm not sure, is this on?
Yep.
Okay. You hear me okay? Good morning. It's good to see all of you. We apologize, both Dr. Gann and I were out for the December meeting, so I think it was abbreviated and we weren't able to expand on some of the work, but we're back. And glad to meet with you, glad to expand some of the information for public health. And today, what we have planned, you were sent electronically, you were sent the full report that talks about heart disease within the Cherokee Nation. And today you're given somewhat of an executive summary that we're going to go over that talks about heart disease within the Cherokee Nation that Dr. Gann and his team in our surveillance and monitoring have been working on for actually probably a year or so. And we want to talk about heart disease today because it is the leading cause of premature death and disability within the Cherokee Nation. And we want to talk about why it's important to public health and what we're doing about it right now and the path that we're going on. And then we'll field any questions about it and hopefully have some good discussion about this serious topic in the Cherokee Nation. So I'm going to turn it over to Dr. Gann right now.
Thank you. So this report was a team effort with Dr. Julie Stoner, who's the chair of the Department of Biostatistics and Epidemiology at the University of Oklahoma Health Sciences Center. She and another PhD there helped me collect the data, and they wrote a majority of the report based on the data we gave them. Like Lisa said, the reason this is a focus is because overall, heart disease is the #1 killer in Cherokee Nation. It's also the #1 cause of early death. And I think that's what's where we try to focus. If you look at the executive summary, the first pie chart shows that the majority, about 53% of the people who die from heart disease are less than 75 years old, right? So kind of dispels the idea that, well, you know, it's our very old people and you have to die of something and it's just the way life is, and it doesn't need to be. And then if you just look at our patients, that second pie chart, I looked at all the patients who came to our health services in calendar year 2018, and of all the people with a diagnosis of heart disease, 57% were less than 60 years old. So if you look at the age breakdown in a table of the age of death for the 5 years that we looked at, there are people in their 30s and 40s who are dying from heart disease. And so why this is a public health issue is because heart disease is largely preventable. Cigarette smoking is the #1 cause of death and disability in the United States and in Oklahoma and in Cherokee Nation. It's a major risk factor. Then you add in obesity, lack of physical activity, poor nutrition, and then, like you've heard me say before, this whole behavioral health cloud that affects everything that we do. So fortunately for heart disease, there are a lot of different ways that we can measure what is happening in our community. And beyond the people who actually walk through the doors of our health system. So there's a system called the Behavioral Risk Factor Surveillance System that the state runs. And we're working with them to oversample Native Americans in Cherokee Nation to get better numbers, but we can look at how many fruits and vegetables people eat, and obesity, how many people have been told they have hypertension and diabetes, physical activity, all those things we can monitor and we can track. Are they getting better or getting worse? And then, of course, we have the vital statistics system with the death rates. Still, we have a problem with people who are Native American, when they die, they're listed as white on their death certificate. So that has been corrected up through 2015, and it makes a huge difference in our numbers. 30 to 40% of Native Americans in Cherokee Nation, when they pass, are listed as white. So CDC and the Indian Health Service has worked with the state to correct that, but only through 2015. So we don't have any data later than that on mortality in this report. CDC knows it's an issue, and there are a lot of people working on it. So we talk a lot about lifestyle, but it's not all personal responsibility. We know in public health that the environment that someone lives in makes a huge difference, and we've talked about that before as well. Putting in a sidewalk is a health benefit. When they redid 4th Street here in town and put in the sidewalks, it makes a difference. Access to healthy foods, access to health care is an important part as well. And there are ways we can measure that. Part of my job in the surveillance department is to regularly produce these reports on specific health conditions. We're in the middle of writing a report on cancer, and for Cherokee Nation, that's the #2 killer. So you'll see that in the future as well. The technical report, the larger report that you got by email, is more of an academic type report, and we will have this report made available to the public more thoroughly after the vetting is finished for that. So it kind of documents permanently a lot more information than what's in the executive summary. But I ask you to read through that and think about policies and systems that we have in Cherokee Nation and how all of those affect health, in education and housing, in all of our human services, and how important that is to the overall health. So after reading the report, were there any questions anyone had about it?
Mary?
Yes, Dr. Gann.
Yes, ma'am.
I really appreciate getting these statistics, and they are so alarming. By any chance, did you all do the breakdown between men and women?
For this report, I don't think we did. You see in the larger report. No, ma'am. The risk factors, the numbers aren't high enough to really do that. And mortality, I don't think we did that either. But it's easy to do, and I can send that.
I was just wondering if there were any similarities or differences, since so many of the lifestyles are the same, that has led to this alarming report.
Yeah, I'd have to look at that. I can send it to you. It's pretty
Thank
easy.
you.
Yes, ma'am.
Sean?
Doctor, did you get most or all or some of these stats from our health facilities?
The only stats I received from our health facilities were the costs for medications. That's in there. And the estimated cost to our contract health services, then the number of patients. So those are the 3 statistics.
All right, pardon me, like the number of people who have heart disease. This may be an easy question.
That's okay.
But how did you get that number?
That number was estimated from the behavioral risk factor surveillance system. And we also compared that to our numbers. Now with the pie chart I showed you in here on the number of patients, that's just people who visited us in 2018. But if you look at the pharmacy numbers, there are 45,000 people on heart disease medications. So kind of 2 different sources of data that don't always line up. So those are kind of estimates, but they're good enough that we can track. So we can look at it next year and see if it's going up or down.
Is there any way to tell per district in the Cherokee Nation or area?
For patients, we can do that. With the behavioral risk factor surveillance system, the numbers are way too small. If you're looking at obesity rates.
It'd be interesting, I'm sure, to each of us to know where our districts
Now,
may fall in that.
Our health survey, which is we've been talking about for a while too, we just need a couple more completed surveys to get that done. We'll be able to look at county level data on smoking and obesity and many other health factors was the reason for the survey. So we'll have that probably by the summer. We should have a firm report on those numbers. But that's a very expensive, very difficult study to do that we can't do annually, but hopefully we can do it regularly.
Sir, while I have the floor here just a minute, it pertains. The Maroma facility. Now that's a positive thing for Cherokee. I guess everyone would agree. You know, over the last 4 years, you know, I've heard of the things going on at Maroma. I've even played a little ball there, believe it or not. But mine and Canaan's area, I know he gets the calls. I'm curious, the funding. Do you remember, Buell, the funding that set up Maroma? My interest is our folks, and I'm sure Sequoyah County, they're geared up, chomping at the bit. And all districts, I'm sure, they are chomping at the bit for something like that. And, you know, I've kind of laid low talking about that for the last 4 years. But are you familiar with, are there grants and any type of funding? It would be an easy thing to find out who funded that, who bought it. I know it couldn't have been community assistance money or special projects money. But do you have any information on that, Lisa?
Yeah, yes, I do. I was here. It's called the Males Seminary Recreation Center, and it's been in operation as of this October for 10 years. This past October 2018. Maroma, as most people refer to it, was funded. Cherokee Nation bought that property, as you know, the Maroma properties, sometime beforehand. And that is an old facility that was used for the school. It was their gym and their PE and some, their basketball courts and all were in there. When Cherokee Nation acquired that property and we're trying to figure out what to do with those buildings and what to do with it, there were a group of people that came together and had been citizens actually asking to play basketball in there. And so a long stretch, but what transpired is that it was funded with tribal money. It's funded from the general fund, as I understand, and it was meant to be somewhat of a pilot to have a facility that was different than most gyms, in which you had access for families to do all kinds of different things, such as, mom and dad or brother sister might be playing basketball on the court and people are upstairs using the cardio equipment. We have child watch to take care of kids while you do that. We have classes going on. So it was meant to be somewhat of an experiment to see how well it worked. And needless to say, it has been extremely successful. It's been more beyond our wildest dreams as far as participation. Now, having said that, it is a costly endeavor every year. It is still funded out of the general fund, and it costs all of the staffing. And one of the reasons that it is so successful is that we hire master level trainers and very qualified staff. We have great child care staff in there, and to maintain and keep that staff and keep everybody going. People are able to come in there and get personal training. If you're a first-time exerciser and you want to you can either go to a beginning class or you can come in and do work with the personal trainer. So there are a lot of services that a lot of other places don't offer. So when we look at this, what we have to look at it can't be really looked at as a business. It has to be looked at as an investment in the future. We've talked about ways to try to link the folks that come to the Male Seminary Rec Center to health outcomes. However, you can see that would be extremely difficult to do. We don't want to infringe on privacy, and it's a difficult task to connect those two. But it is still funded that way. It is very successful. As far as grants that are out there right now, I will tell you, we comb grants. The grants department here is great about finding things. A lot of things that we find are very small money-wise when it comes to operating a program, operating costs. There are programs out there occasionally, usually private foundations, that might fund construction of something. And those are pretty few and far between, but the real concern is the operating costs, which continue to go up every year. So those kinds of things have to be a collective decision of everyone sitting down at the table and deciding what's there and what we want to invest in, and how we want to make that happen in the future. But we in the health division, and especially in public health, are here to serve and help. And although that is considered a tribal facility, health services operates it for the tribe, and we're glad to do that. And we work in conjunction with tribal facilities to keep it going, and it's been a great success. So.
And I would like to head up a work group, and I want to be on that and see who I can get on board and successful. And it, of course, doesn't take a doctor to know if you're going to exercise. That's going to help you. And you know, the Tahlequah facility, that's great. I'm proud of it. This is where our headquarters is. But the workout thing, you know, unlike some of the departments and services, I mean, we come to get it here, then we'll go back. You know, none of my folks are going to wake up in the morning. It's really for Tahlequah, that facility, and it's great. But I want a work group, and I'm sure I won't be on by myself. But that's going to be one of the priorities in the future. Whoever's in that district, it's a needed thing. So, anybody want to be on that little work group?
I do.
I do.
If I might expand upon what Councilor Crittenden brought up, of course, Dr. Gannon, we're talking about health disease, and he briefly mentioned the different preventive measures we can do to lower that, and he didn't even say exercise. It's kind of a given. But I hear you, Councilor Crittenden. I hear a lot of concerns about citizens outside Cherokee County, outside districts 1, 2, and 3. Well, they have direct access to a facility. And you mentioned some grant possibilities, maybe long-term, but short-term, we might need to think outside the box a little bit. I know in my area, there's a Cherokee citizen that owns a health facility, you know, with weights, the whole deal. And he wouldn't provide to him for Cherokee citizens to come and be a member of that gym. So I don't know how prevalent, like in the community of Salisaw, is there a private gym?
Yeah, that's the census. In our districts, I know them all.
Yeah.
And I support them. But that's a separate thing from it. You know, the ones in town don't have a gym. But I agree with you, and I will do some of that partnership with some of the special projects money. But this little work group, not mine, but it's going to, by golly, be to get a Maroma style thing in my district, and I know every district has their ears perked up, but I don't want anybody to mistake me for not supporting the local business folks. But this is a bigger picture here. But thank you.
Okay, so for clarification, Sean, you wanted this work group to be formed, and you want to be a part of it. And was it Janice, Canaan,
Brian wants to be.
Ewell? So would it be too ambitious for your subgroup or your work group to look at the possibilities and report back to the next public health subcommittee meeting? Be 2 months from now.
Yeah.
Just say these would be some legitimate possibilities.
I'd like to be on it too. Throw me on there.
Okay.
How many can be on it?
9. Well, how many are in this committee? Is everybody in it, Sean? No, there's only 12, but you can't have a quorum, or it has to be an actual meeting.
Right.
So you need to have 8 or less.
So how many we got now?
1, 2, 3, 4. There's 6. Yeah. I've got Sean, Janice, Buell, Brian, Canaan, and Junior.
If you're short of 8, I'd like to be on it, but if you got 8, then
That's 6. You would be 7.
okay, go ahead and put me on there then. Okay. Brian, let's see, hold on just a second, Brian, if I could. I got Canaan.
Yes, I'd like to have Canaan on there for sure.
My questions were right along those same lines that Sean's talking about. I couldn't agree with him more. Something that jumps out reading this report is you look at the money that we spend on heart disease and contract health alone and medication loans, over $8 million. So if we were to invest that in preventive care, do you think, I mean, obviously I would think that there's going to be some correlation there, but would it be trackable to look into how much a wellness facility would combat the contract health dollars and prescription dollars that we spend on heart disease?
I think there are possible ways to potentially look at it. One of the things that all of us know is that this is a multi-causal disease, and there's not going to be one thing that you do that's going to make all the impact. It's not a magic bullet type thing, but it's certainly one of the solutions. I think there are potential ways to look at that. I always caution when I work on public health projects and when I come before you for everyone to understand that we are very much invested in our clinical delivery as well, and that making the decisions, I think it's really hard to look at money and say, we know what we're spending, but it's also hard to say, you can't take that from care, because that's the humane, we have to do that. We still have to care for people. And that's where we come in looking at other creative ways. And what I would say about building or putting these structures and these programs in communities is that the most important piece is that it's a collective community effort. The reason that Maroma is so successful is because we look at the scientific evidence that shows why people start exercising and why they stay exercising or they stay involved in physical activity. And a lot of that has to do with, one, access, easy access, but two, social support. And what happens at the Male Seminary Recreation Center is either they get involved in a class and they develop a lot of social support and friends in that class, or their entire family finds something to do at the same time. Somebody might be going to spin class, someone's on the treadmill, someone's playing basketball, another person is doing something else, and there's that access to taking care of the entire family with child watch. So those are the kinds of things to remember. To have a facility, I caution people against a facility that just has exercise equipment in it, kind of a build it and they'll come. I always say you have to build it around what interests there are in the community and how can you attract something the entire family can get involved in. And I think it's the way of the future. I think it's a fantastic idea, and I think there are certainly enough creative minds within the Cherokee Nation and within all the resources that we have technically to be able to look at great ways to evaluate something like that. So,
those dollar amounts just jumped out to me, and you said it best really when you said that it's not a business, it's an investment.
yes.
Because, you know, if you're investing dollars into a new facility or a new program, then you're probably going to not spend as many dollars in contract health services when it pertains to heart disease or diabetes or whatever it may be.
I'm excited about the amount of people in the communities who are asking for these things. I would call myself a motivated exerciser anyway, but I would say that I spend a lot of time at the Male Seminary Recreation Center myself because of the social support and the access. Easy access and social support that I have keeps me coming back when I might not feel like getting up and going that day. So I definitely think that all of our team is an advocate for partnering with everyone to make things local solutions in communities.
Okay. Keith?
Yes, you spoke of the longer version report and that it was emailed. Did you, I don't recall seeing that.
It was last night. It was
Last
pretty
night.
late.
Okay. I was just wanting to make sure, because somehow that escaped me. When did you send it?
I sent it last night to Shelley to distribute to the council, knowing that they were going to provide you guys with an executive summary, but we wanted you guys to have that extended report for review, and it's pretty intensive.
Good. The question is, when did you send it?
Technical. Oh, I actually gave it to Todd earlier in the week. It went through our governing board last week and week before last, and we discussed it extensively. And Dr. Gain and I have been looking at it to double check and make sure there were no incorrect numbers and just vetting it. So if the lateness is our fault, I will take the responsibility for that.
When did you receive it?
I don't recall. It's probably
Maybe Tuesday, Monday or Tuesday.
So I'm getting around to why did we just receive it last night, where we wouldn't have had time to read it and digest it?
Well, to be honest, Lisa and I had a little bit of discussion making sure that they were prepared to release it. And I was involved in a couple of meetings over the last 2 days that were all-day meetings. Once I got out of that meeting, I called Lisa to make sure that that they were okay with the final version before we released it. And that's when I sent it.
We apologize for that. We'll try to make sure in the future that you have it in plenty of time to
Just,
take a
you know,
look.
when it's complex something and don't get it
Absolutely.
literally in enough time to read through it.
Did you have a quick question? Oh, I'm sorry.
We do have in each,
I just never
in
understood
my,
why they need it.
in Claremore, we do have the Claremore Expo Center, which has something that mirrors a lot of what this has to offer. And it's like, I think we need to kind of find out what's in communities and see how can we work with what's there instead of duplicate. Like you was talking about with the private businesses, work with what's there and, you know, work together instead of, because we just can't build everything, but we can assess what's there and then work with, because there's things in communities.
Quick question, Victoria?
Well, I had a comment about the report, and then I had a comment about what we're talking about.
Okay, go ahead.
I got that report about 4 or 5 o'clock last night, but I kind of felt like it wasn't meant that we were to read that, you know, now and in the future. So in your defense, I just didn't feel like it was something. I didn't read the whole thing last night because I was too tired. But I wanted to say that in my district, in Bonita, we have the beautiful health center that has a wonderful fitness center. We also have a great nutritionist, and I have taken part in 2 of those things. The nutritionist does a wonderful job with just meeting one-on-one and talking about your weight loss goals and things like that. And of course, our clinic is 8 to 5, 5 days a week, but the fitness center is open to people to come, I believe, almost 24 hours. But like what Keith was saying, seeing that we have a lot of things covered within our clinic, I feel great about my district having, they've got Nowata, and then they have Oshaleta close to my northern end, and then Bonita serves, you know, like Afton and, Adair and Welch and those areas for people that can want to drive there. But if you could, Sean, if you ever had an opportunity to go visit like a place like that, like Bonita, that has those things incorporated in the clinic, then it would give you an idea of what you'd like to see. And I think there are tracking systems. It's a commitment on the person to track their progress, but also they're very open to having you call them. You know, I can call the nutritionist anytime and say, hey, I need some more of those forms so that I can keep a diary of what I'm eating, or I need, and my primary care provider sees me every 3 months for blood work just to see that I'm on track with, so that I don't develop diabetes. So there are a lot of preventive care things just in our clinic that would be very, very good things to look at for what you want in your district. And that's the only reason I didn't hop in to be on the work group, because I have the facility.
I mean, that's great.
But I'll be happy to help
Yeah,
if
that's
you have any
great.
questions.
Mary?
Thank you.
Yes, a couple of things. Councilor Warren and I were just talking here, and we think it's a good question. Todd, why did the report go to you instead of directly going to council?
Basically, from an administration standpoint, I'm there to try and help collect and make sure that all reports get submitted in timely. So I work with all the executive directors and the teams that report to make sure that the reports are submitted in a timely fashion. And so I'm the central point of contact in administration to make sure that report gets submitted. So I pester all the departments to ensure that they submit the report in a timely manner. And Lisa and I have been working and talking about the Public Health Subcommittee, making sure that the report was ready. And so that's why I'm the central point of contact, so they and I harass people if they're not submitting in a timely fashion.
Thank you. I appreciate that explanation. I have a question. Goodness knows that Councilor Crittenden has just gone insane over the fact that his district, and rightfully so, had that death rate, you know, in the United States, and we all feel this way. But I have a question. At the Man Killer Clinic, if you're dead, and we're all going to die basically of a cardiac arrest, right? I mean, our hearts are going to quit. My question to you is quite simple. Is it possible that somebody had pneumonia and they died of pneumonia, and they show up and they bring the body back and the medical examiner says cardiac arrest, because that's ultimately what they died from? Is it possible there's someone at the Man Killer Clinic who literally documented everybody that came through, they had a cardiac arrest, which increased our numbers here and nationwide, and is this a possibility? Have you all checked that out? Because ultimately we will all die of a cardiac arrest. Is it possible, instead of saying they died of stage 4 cancer or 5 cancer, is it possible that you could have died of pneumonia? Is it possible you could have gotten hit by, but ultimately somebody in a hurry wrote cardiac arrest? Is that a possibility? Has it been explored?
It has been explored. I worked with the State Health Department, the Department of Vital Statistics, to ask them the question, and we were exploring diabetes because, you know, diabetes has a lot of sequelae that can cause death, kidney failure and heart attacks, and sepsis and all those things. And their answer was quite simple. It's whoever's filling out the form writes the primary cause of death, and that's what goes into the database. So talking with my colleagues, you know, a lot of death certificates are filled out by funeral home directors, medical examiners, but also by physicians. And the physicians look at the, they call the primary cause of death. So if someone dies from kidney failure due to diabetes, they're going to put kidney failure as the cause of death. That's about as far as we went, because I was trying to figure out what was the best way to describe mortality rate from diabetes. And I haven't figured it out yet for that reason. So that's the most we know about it. So
it is possible, what I just said, the funeral home director, the medical examiner, without having access to a chart, could easily say this person died in that area of the state, in our Cherokee Nation. It's possible they just wrote cardiac arrest, and that inflated the disease numbers, which changed the statistics for Councilor Crittenton's district.
Yeah, I think it could, but you know, cardiac arrest really isn't a diagnosis. And I mean, picking words with you, like it would be, you know, heart attack, right?
Heart attack, cardiac arrest. Let's call it either thing.
Yeah. So I think.
Do you understand what I'm saying, though?
Yeah,
if we have somebody over there when they bring a body in, or some doctor, the ER doctor, whoever's signing off on these things, and it's easier to just write cardiac arrest. This could have inflated these numbers in Councilor Crittenton's district.
Yeah, I'm not really sure. I can't really quantify that for you. But, you know, when I think about the race issue, I think that's what happens. They look and say, yeah, they're white, too. You know, and there's not an in-depth investigation into, you know, what the race is. So, yeah, I don't, you know, there are people, I don't know the laws very well, but you can imagine someone passes away at home and they go, there's nothing suspicious, they died of natural causes, and the funeral director is there with no information trying to figure out. So I don't know how they do that.
My suggestion, and I don't know if it's even plausible, would be, is it possible that we need to educate these people, or just a friendly inquiry, you know, is it possible that you are writing cardiac arrest when maybe they died of complications of diabetes or pneumonia or something? Because of the staggering number of how this reflects in heart disease to our people, especially in this district.
I can answer just a little bit of that. It's Ms. Dearwater Anderson and I were at CDC last month for a couple of days worth of meetings, and the CDC, in conjunction with a couple of other national organizations, is investigating what Dr. Gann talked about earlier, which is called racial misclassification. But at the same time, they're talking about projects working with funeral home directors about the accuracy of filling out those and the importance to vital statistics. Okay. So those projects are going on. I think they're accelerating a little bit because, you know, there's such a hunger for local data and information to tell you about your local community. Getting that information is expensive, time-consuming, and so that is what a lot of research and a lot of people are looking at right now, is how do we come up with local, accurate numbers to describe to communities what their health status looks like. And so in that same realm are the things related to vital statistics and making sure that the cause of death is not only the race of the person, but the cause of death is accurate. And a lot of that, as Dr. Gann mentioned, falls on the funeral home director in a lot of places across the country, and working on projects to educate funeral home directors about the importance of it for shaping what we do in the future to take care of our communities. So,
I appreciate that explanation, but there is this strong possibility that there's somebody that inflates our numbers. That is a possibility, though.
Are you speaking to the life expectancy study?
Yes, I am.
Okay, and Dr. Gann could probably give you a little more updated information quickly about that. We have investigated that since our last meeting.
Sure. So we worked with the primary author of the study, Dr. Elizabeth Arias, who's a brilliant woman who's done a lot of studies on life expectancy in Native Americans and very well published. And if you recall in the study, CDC looked at over 60,000 census tracts, right? And received data from every state except Maine and one other state, and just a giant pile of numbers. They ran the numbers, and the purpose of the study was to see if this new method they were using worked. So they did some checks on their data, it seemed to work, and that was the conclusion of the study, that this new method that hasn't really been done before seems to be accurate enough for us to do some more. So when we asked her to look at the numbers in Adair County, she found that the study covered 6 years, 2010 to 2015, that there are 1,408 deaths in Adair County during that 6-year period. So they took those deaths and asked the state, give us the addresses of all these people and their age when they passed. And out of that 1,400, there were 111 that they couldn't code. I'm sorry, there are 196, so over 10%. She said that nationally, if you look at all the death certificates they received, only less than 1% of those they couldn't get a good address for. So for Adair County, it was over 10%.
Election time too. But go ahead. I'm sorry.
So and that falls on the state. You know, they just have an address that's on the death certificate. So those were left out, and there were also 85 deaths where they had 0 records at all. And then there were 91 deaths attributed to a single address in Stillwell that appears to be a nursing facility. So the idea is that people live somewhere else, they went to the nursing facility and passed, and that's where the death certificate said they lived. And so if you recall from the map, Adair County had 5 census tracts. And if you look at the lower half, there were 3. Stillwell had a little circle, and there's one to the east and one to the west. They combined those 3 together and put those 111 deaths. They knew they were from southern Adair County, but couldn't place them exactly. Added those in there, and they came up with a life expectancy of 70.9. So if you combine southern Adair County, they couldn't run the numbers by removing those 91 deaths from the nursing facility. They ethically, you know, their methods wouldn't allow them to do that. But they could combine those 3 census tracts, 70.9, which is quite a big difference. So that makes, so I don't know exactly what to do with that, but to say that for Adair County, their method didn't work. And it's, you know, it's not CDC's fault. It's just the accuracy of the data that they have, and they did the best they could with it.
If I might say that we know that, as Dr. Ginn said, it obviously didn't work that well for that census tract. And last month when we were at CDC, I had the opportunity to speak before the whole committee, and I spoke briefly about this, and I talked about the repercussions of it, and that we would ask that they be more sensitive in smaller communities, especially Native communities, when this information is released, and to maybe be in more contact with us if they know that this is coming, going to be published or going to be out in for general consumption, so that we can talk about what our solutions are. And I stressed to them the burden, even though it was in Adair County, that the burden sometimes falls to the agencies and the groups, and especially the Cherokee Nation that are working in that area, and that to think about when they're working like this and they're releasing information, the end results and the unintended consequences of what might happen. And we stressed to them that that was an important piece of our work, is to stay ahead of those things, and in our government-to-government relationship with the CDC and the federal government, that we would encourage highly that we be involved in future studies.
Brian?
Yes, sir. Thank you. I would like to say thank you guys for taking that to the CDC, and Julie, thank you very much. I think this is really important because what we're seeing here is a lot of, everybody's got their own ideas, but I think we're starting to really get at what is public health, and that's the intent of this group. That's the intent of what it's always been. I mean, we're already behind, whether you want to look at the dollars, whether you want to look at the individual, or whether you look at the entire community as a whole. And you know, our life expectancies as a group all together, people are living longer, and it's going to continue with modern medicine, and healthcare is going to rise. And this one thing I really like, you know, the things that I've seen in this executive summary, because when I listened very closely with some discernment with Dr. Gann, that other report was very academic. So it's not necessarily a report that everybody's going to take in and digest in a day, but this is something that we can digest. And what I would like to suggest or see is, you know, we meet every other month, and maybe we get an executive summary report of what, you know, what I like is what are we doing about it? Because, I mean, the problems identify themselves all the time, but this group here identifies solutions. And they look, and on this work group, if we don't have Lisa on there, then we're missing the mark already. I mean, we've got to set out a framework for me, and the key word she said earlier, social support. I mean, this guy right here, I did yoga for like 2 years when my back went out, okay? And the chiropractor told me, you can keep coming and giving me money, or you can go join a yoga class. Well, I joined a yoga class, and it was all some of the toughest men in Sequoyah County that I've ever seen, and we're all in there at 5 in the morning doing yoga, and it saved my back. But I wouldn't have stayed if I didn't know that, you know, that Johnny Dale was there and that Todd was there and some guys that I looked up to, you know, and that social support, it's key. And whether we talk about elder care, which is always a hot topic, you know, because it's important to all of us, let's make no mistake, or our kids or our own health in the middle. Public health is at the heart of that issue and at the center of that. And I would say, I mean, if that's something that you guys can do for us, is like, what are you doing? And let everybody here know, because the leaders, the CDC is looking, what's your leadership doing? And that's going to move the needle more than anything of what we can do. But we have to set that frame. We have to be mindful of I'm not even looking at the feasibility of it. It's we're going to do something, but what does that something look like? Whether it's partnerships or whether it's everything that we do, but we have to have this group, because this is the A team for me when I have these issues. And we are, again, public health accredited Cherokee Nation, okay? And we have to take that and use it, but we have to have the analytics too, and that's where Dr. Gann and his group and Dr. Comerford come in to play and look at that data. And I don't want everybody to get hung up on the data, but it's very important. But at the end of the day, we all want to see healthier people walking into the clinics to get whether it be a well child checkup. I hear well child checkup in my mind all the time, because when I take my kids in, and that's what I want for myself, that's what I want for my neighbors, that's what I want for my tribe. And but good stuff today, and I mean, and everything that everybody's looked at. But if we come in with some guiding principles of what we want to do within this work group, and I'm with my friend Sean on that, but we need to make sure that it does work, but that we remember from now on, I don't think we ever leave public health out of health care, because that is the central portion of it. So thank you, Doc.
Janice?
My question is, these charts, how do they compare to the population as a whole?
Right, so some of these numbers are difficult to compare because we're using healthcare numbers. What I can tell you is that heart disease is the #1 killer in Oklahoma and in the United States.
Regardless of race.
Regardless of race, right. So I can make some more comparisons to Oklahoma and get you some actual numbers to compare.
And I guess my question is, Oklahomans as a whole are 50% of the people being treated for heart disease less than 75 years old. More concerning is this 20 to 59-year-old. I would be curious to know across races if statistics are similar or if we are unique in that.
Sure, I can get that to you.
Thank you. That's all I have.
Todd?
If I can, just a little bit of my background and history. I've worked extensively with Lisa on the Maroma program when we designed, developed, and constructed that. So as you guys form this work group, if you guys are interested and have any assistance, then you can. Secondly, there is a book published by Gallup, and it's discusses the 5 factors of happiness and well-being. And a lot of the data that Lisa shared with you guys is actually referred to in there about partnerships. You're actually more likely to continue a healthy workout with a friend, even more so than a spouse. And so there's a lot of things that we learned through that study. If you guys haven't, I would encourage you guys to read that book. It'll shed a lot of light on a lot of the things that public health does. And I want to apologize for you guys not getting that report. The thought was, between Shelley and I last night when I sent it to her, was to go ahead and send that to you guys in email format because it's lengthier, let you guys digest it over the next 2 months, and then if you have additional questions based on that, then you could follow up with it, knowing that you guys were going to get the condensed report presentation today. So that was kind of the thought, and if I did that incorrectly, I apologize, but that was the thought behind it.
Okay, if I may, Dr. Gann, Lisa, do you have other items on your agenda here?
No, I think that Councilor Warner had asked about what we're doing, and it's briefly mentioned in this executive summary. If you look at the report, the full report, there's a more extensive list of the activities and things that are going on within public health that we're doing in relationship to not just physical activity, but obviously nutrition, access to care, all of those things that have an impact on early onset of heart disease. And we would be happy at the next, since we're running out of time, at the next committee meeting to detail more about those things, provide a report of the things that we're doing, and talk more about what it is that we actually do on a daily basis within public health. And I would be remiss if I didn't mention that there are other programs working on public health efforts throughout Health Division that are extremely important. Our partners, the DPP program, there are partners in helping deliver that curriculum to community members, a great curriculum and a excellent nationally recognized program that is the Cherokee Nation is very fortunate to have. There are other programs, public health nursing, clinical delivery programs that work specifically in public health too, that are our partners, and want to make sure that all of you understand that they are working really hard on public health as well in the communities.
Okay. Keith?
Yes. The report, you know, it did a great disservice to the community. And Councilor Cretton was very righteous to be indignant that needed to be dug into. We spent time, effort, energy, resource to dig into it. These people release it to the media. The media grabs hold of it and splashes it all over the place. Sure, they've acknowledged it, but are they acknowledging the damage they did? Are they releasing a big public report that now says, oops, we were wrong, and we apologize to the people of Adair County? Are they doing that?
That's a great question. I know that a lot of people have asked me that and asked the answer to it, and without getting too complicated, and just a real short, no, they are not. And the reasoning behind that is a little bit to what Dr. Gann alluded to, is that these are scientists who took numbers they were given and crunched numbers. And so in their minds, technically, they crunched the right numbers they were given and came up with the right numbers. Digging deeper into it, their intent in that particular group, and their, CDC is huge in the groups that work on different projects, their intent was to look at the math and see if the math worked. And in their mind, the math worked. So as we start digging more into it and looking, CDC was very willing and helpful and responsive to sit down with us at the table and talk about what there could possibly be going wrong. But as we start to dig more into it and see all the players that are involved in it, you're looking at the death certificates from every state, and they had an agreement with every state to gather the death certificates, and that went on and on. Placing blame on one agency or one group of people becomes a little more difficult. I think what was absolutely unfortunate for us is that there was someone at the Washington Post who didn't have a lot to do that day and picked it up and started digging through it. And that one particular article is the one thing that has spun all of it. And
so is there a way to get this reporter and ask them if they would correct the misinformation?
You know, I actually spoke to that reporter a couple of days after the article came out, and that's where we first started our digging. Is I emailed him and I said, I need more information. Could you please? And so he referred me to a couple of people. But since that time, I've not made contact back with him, and that's something that I think probably in conjunction with our communications department and our administration and all of us together could definitely ask this reporter, could you revisit this initial report? Do you understand what has happened based on this information that you provided? Because obviously he interviewed some folks from Stillwell in the article that I read. So
Our local media was, I mean, they were just all over it because, you know, they had their news trucks down there the next day. And we do have relationships with our local media.
We do.
We have relationships with the local media to say, are you aware of this? And would you like to do a follow-up story to make sure that this information is told in a more correct way with this new information in place? I think we owe that to them.
Actually, our communications department is preparing and doing that right now. As we have a meeting this afternoon with a representative of the communications department to talk about a response and to talk about reaching out to do that very thing.
Thank you.
So.
Sean?
So that's, thank you guys, and just, I'll be quick here, but like Brian, preventative, public health, I mean, you guys are stepping up and doing that, and I thank you, and please be a part of the work group. And Taryn, are you the administration liaison for now and can come for that, and we'll get that set up. And so Dr. Gann, so if someone would ask me about that, and I can tell them my respect for you guys, our opinion is that was wrong.
That number's not accurate.
Number's not accurate, and
I think importantly, the report wasn't written for public health departments to make decisions and formulate policy and programs. It's not why they wrote the report. The heart disease report, that's why I wrote that.
Right.
You know,
right.
And so that other report.
But I thank you for investigating the other.
Oh, sure. And I learned a lot about it as well. And Dr. Arias, the primary author of the paper, when we told her what was going on, her first response was, "That's not what it's for." You know, she was devastated. She really.
As part of your meeting on communications, are they going to mention Channel 8?
I'm not sure right now.
Right,
I think I'll know more after
and,
this afternoon.
And I think everyone in here would say their district can improve on lifestyle. Everyone in here can, and my district can. You know, the deadliest city in America, and Mr. Well, I won't even say his name, but he signs off. People are looking into this. Stillwell may not have much time. You know, and that just, I know we need some improvement like everyone, but thanks again for what you do, and I'm finished.
Good.
Thanks.
I'd be interested to, I know this may be a long-term thought or project. I'd be interested whether our life expectancy in Stillwell is similar to the life expectancy with an urban Cherokee, saying Claremore. You know, is there a difference in life expectancy between a urban Cherokee versus a rural Cherokee? I'd just be kind of interested in that. Because I know in Tulsa I've seen 3 separate epidemiology studies where there's a 14-year difference in life expectancy based on zip codes.
Yes.
Tulsan here, you go 3 miles away, and all of a sudden their life expectancy is 14 years less. And it wasn't a one-shot deal. It was, I've seen 3 different epidemiology studies. So.
And if I could just make one comment for Councilor Crittenden, we're not finished looking into Adair County, and I don't want to cast a light that everything in all of our communities health-wise is just fine and there's no work to be done, because there's plenty of work to be done across not only our communities, the entire state of Oklahoma, for that matter, the entire southern part of the entire United States. There's tons of work to be done, and we're still working on that, and we are working with some partners out of Oklahoma City to dig a little bit deeper into what's going on in Adair County and to talk to some key leaders and really try to figure out what we can do to help improve the health of all of our citizens and all of Adair County and all of Oklahoma. And we look at ourselves as conveners of people, and hopefully we can play that role to convene people to help find local solutions. So.
Thank you.
Okay. I'm looking here, no old business, no new business. Any announcements? Thank you, Dr. Gann, Lisa. Thank you all for coming. Our next meeting is tentatively scheduled for Thursday, April 25th at 11. I would certainly entertain a motion to adjourn.
So moved.
Second.
And a second. All those in favor?
Aye.
Any opposed? Okay, we adjourn.